Geriatric PT, Chapter 26, Patient Management in Post-Acute Inpatient Settings. First, we're going to discuss inpatient rehab facilities, or IRF. The purpose of the IRFs is to provide multidisciplinary, team-oriented services to patients with intense rehab needs. For Medicare and most of the payers out there, there's specific criteria that must be met. With these IRFs, the criteria that needs to be met is that there's reasonable and necessary care and significant rehab potential for this patient. It is required that they have coordinated care of at least 2 therapy disciplines between PT, OT, and speech. And the patient is required to participate in a minimum of 3 or more hours of therapy per day, at least 5 days per week. You are not allowed to do a trial admission to inpatient rehab facilities. You have to have a plan to discharge the patient to community. So when thinking about our patients, we need to know what the end goal is. So kind of discussing about the assignment that you all have due in the next few weeks, you have to make sure that your patient is going to be able to go home in order to send them to an inpatient or an inpatient rehab facility. So you have to keep in mind, what are the end goals for the patient? What's the likelihood of them being able to return to their home environment? You have to understand a little bit more about their home environment to know whether or not that's going to be a safe place for your patient to go. So in the short term, we're thinking about this in regards to our patients, the assignment that you each have. But in the long term, we need to be looking at each patient as they are in front of us to know what's appropriate for them. The IRF is paid for by the CMS 13. So there are some specific criteria that must be met in this area as well. So 60% of the patients that are admitted to the IRF must have what's called a qualifying diagnosis. Previously, this was up to 75%, but a little over a decade ago, there was a rule that went into place that said that it cannot be more than 60% of these patients must have this qualifying diagnosis. And we'll discuss that further here in just a moment. Medicare payments are paid via the PPS, and that's known as the prospective payment system. That's important to understand because that's going to determine how you're going to get paid for that patient as they're in your inpatient rehab facility. In 2004, CMS eliminated the unilateral total knee replacement from the CMS 13. So with these 13 diagnoses that we'll discuss in a minute, there used to be one that allowed somebody to come into inpatient rehab that only had one joint replaced. But now you have to have a qualifying diagnosis, and this does not count as one of them. Like we just mentioned, the payment is made via prospective payment system, again that PPS, and this is going to be based on FIM scores. This also helps to determine kind of demographic and diagnostic data to determine which case mix or CMG the patient will be assigned to. And this will be really based on what the therapist determines and tests for and asks about in the patient evaluation. This PPS payment, using these FIM scores, provides a set payment that the patient will receive for the entire admission in IRF. This payment is based on the average length of stay for that particular case mix group. If a patient is moved to another healthcare facility, the payment is going to be prorated. So it's very important that you understand why someone's getting better and at what kind of rate you think that they're going to be getting better to be able to discharge back into their community and specifically into their home environment. If, like that third point, the fourth point there says, if the patient's moved to another healthcare facility, the payment is prorated. If for some reason the patient ends up getting sick or has an infection or a fall or can't tolerate the 3 hours of therapy and now they start to decline, they might have to go back into maybe a skilled nursing facility or back to acute care. If this happens, payment is going to be decreased for that facility. So it is very important to make sure that you know who's the most appropriate person to put into your IRFs when you're sending them there. So we discussed the CMS 13. So here are the 13 diagnoses that are included in the CMS 13. Stroke, spinal cord injury, congenital deformity, amputation, major multiple trauma, fracture of the femur, brain injury, neurological disorders such as MS or Parkinson's, burns, active polyarticular rheumatoid arthritis or psoriatic arthritis, systemic vascularities with joint inflammation, which results in significant functional impairment, severe or advanced OA, involving at least 2 major weight-bearing joints and hip or knee joint replacements. So in this case, you can have a single joint replacement, but only if they're extremely obese with a BMI of over 50 or they're 85 or more years old. Otherwise, it has to be bilateral hip or knee joint replacements to qualify for the CMS 13. And Medicare does go back and audit these charts to make sure that the patient actually does have a qualifying diagnosis that sets it apart for the 60% threshold that IRFs have to meet. So beyond that 60%, you can have 40% of other insurances, the Blue Cross Blue Shields, Humanas, Cignas, Aetnas, all that kind of stuff. But you can only have a max of 60% of Medicare patients that have to fall within these specific diagnoses. And that just makes sure that they're not overrunning the IRFs with all Medicare patients, because it is a costly thing for insurance to pay for. So they'd prefer to put the patient in a different facility if that's most appropriate for them. But if they do truly need inpatient rehab, they have to make sure that they qualify with one of these diagnoses. So in 2004, there were some changes that were made to the CMS PPS plan. So again, we already discussed the elimination of the unilateral total joint replacements. CMS determined that these patients could achieve similar, if not better, results in a less expensive setting. So a lot of these patients are either seen in home health or an outpatient, and if neither of those two are appropriate for the patient, then they are sent to a skilled nursing facility. This payment is based on the data gathered, the diagnoses, comorbidities, and demographic data and information, including the FIM scores, and that puts these patients into their proper CMG or case mix group. Each of the CMGs is associated with a specific payment amount for that entire length of stay, and the payment is based on an expected or average length of stay for that particular CMG. So again, we have to make sure that we're putting them into the proper CMG, otherwise we could be risking losing money or leaving money on the table either way. So if the patient is discharged home, you get the full amount. If the patient is discharged to another healthcare delivery site, the fee will be prorated. So you need to have a good understanding of how this works if you're going to treat in this environment. Now moving on to skilled nursing facilities, or SNFs. So common diagnoses seen in skilled nursing facilities are hip fractures, stroke, pneumonia, and heart failure. Based on some 2006 data, the average length of stay in a skilled nursing facility was 26.4 days. Skilled nursing is also known as subacute. So these patients are ones that have had issues going on a long time and they're no longer acute, meaning in either the acute setting or in possibly an inpatient rehab facility. IRFs are seen more for acute type cases, whereas skilled nursing is more the subacute. So even when you see the common diagnoses of hip fracture, stroke, pneumonia, heart failure, a lot of these could actually qualify for inpatient rehab facility, assuming they meet all the other criteria. So again, they have to be able to tolerate the 3 hours of therapy per day, etc. So might come to a point where in inpatient rehab facility, if the patient is not appropriate to continue on for one reason or another, then they might then end up in a skilled nursing facility. So CMS refers to patients in a skilled nursing facility as residents due to the regulations made regarding nursing homes, because most skilled nursing facilities are located in nursing homes. Medicare Advantage plans, and that's insurance that's not Medicare, even though Medicare is in the name, Medicare Advantage plans are not Medicare plans. They typically now require stay in a skilled nursing facility versus an inpatient rehab facility due to the costs associated with that care. So we talked about kind of, the number of people or the percentage of people that can go into an inpatient rehab facility per Medicare. With Medicare Advantage plans, a lot of times they won't even pay for inpatient rehab facility and they must be sent to a skilled nursing facility. Medicare Advantage plans will typically pay a flat fee per day, and typically the case managers are determining the level of care, including the amount of therapy based on the diagnosis. So skilled nursing facility prospective pay system. This can last upwards of 100 days per qualifying episode. They must have had 3-day stay in an acute care facility at least 30 days prior to admission to a skilled nursing facility to meet the criteria for skilled services and skilled interventions. The residents must require skilled services of nursing, therapy, or both. If Medicare is paying, there's a calculated per diem rate determined by the amount of rehab services provided. Now this next section we're going to discuss, but only just because this was how things were paid out as of just last month, so it's September 2019. But into the future we're going to look into how things are being paid out as of October 1st of this year and the changes that took place with Medicare just earlier this year. So the previous assessment was done using the minimum data set, or MDS, and this categorized patients or residents again into that resource utilization group. They also called these the RUGs for the payment purposes. And these assessments were required day 1, 14, 30, 60, and 90, or if there was a significant change in the status of the patient. These RUG levels were paid out based on the specific assessment window, and so the payments can and would vary based on those levels as they change throughout the care of the patient. During this type of assessment, the PTs were determining the RUG levels when they set the frequency and duration of treatments. And this also helped staffing in regards to knowing how many minutes per week these patients needed to be seen based on the specific RUG level they went into. So here's a little bit of information here about the RUG levels, what they look like, just so that you're aware of this. But again, these did expire September 30th of this year. So when a therapist put these patients into different RUG levels, it was based on the minutes needed to treat the patient. So they had ultra high rehab, which was 720 minutes per week, with one discipline for 5 days, plus one discipline for 3 days, and then broke it all the way down to low rehab. So 45 minutes per week of therapy was needed. So 3 days of any combination of rehab disciplines and restorative nursing 6 days a week. So again, that's the old way. Now, moving to the new system. Now skilled nursing payment is done by PDPM, patient-driven payment model. That was just adopted and went into effect by CMS on 10/1 of 2019. This marks a significant shift toward a more patient-driven approach to reimbursement for care furnished to patients in skilled nursing facilities. The idea was to move away from a volume-driven model to one that focuses on the unique and specific characteristic and goals of each patient. And the idea of this was to help classify patients into payment groups based on specific data-driven patient characteristics. So with the PDPM, let's talk a little bit about what's different and what's not. So on the left-hand side, what did change? So again, that patient focus to improve appropriate, accurate payment. The idea is to reduce administrative burden on the providers. There is a new group therapy definition, so you cannot have a combined limit of more than 25% of group and concurrent therapy per discipline, and methodology to determine the functional score and use of section GG data, which section GG is already information that's been collected and had been collected since I believe 2016. So there's no difference in what data is being collected, but it's how it's understood and then how the payments come out on the end. And then on the right hand side, what didn't change? Patient needs. So we need to base our care and our therapy based on the patient needs. We're still looking at medically necessary care as a baseline standard. We want to know what the criteria is for skilled therapy coverage, and so it doesn't change whether we're using RUG levels or PDPM. The use of clinical judgment in determining appropriate frequency and duration. So the therapist still has to put on their clinical reasoning skills and their clinical reasoning hat to determine what's best for the patient in front of them. You still have to document just the same regarding the requirements and the rationale for group therapy, reliance on functional status and presence of cognitive impairment for payment classification, and then again how section GG is coded hasn't changed. So that's still the same for the last few years, which makes this change a little bit easier. Now, since this has only been in effect for just a few weeks now in 2019, there's a lot of questions about it and concerns about whether this is going to be the right move, and only time will tell. So we'll have to wait and see how that plays out. So looking specifically at section GG, because that's the piece where they determine how the patients are going to get their coverage paid for. So they feel like the GG data is highly predictive of PT and OT costs per day. So they have a handful of GG items included. So there's 2 bed mobility items, 3 transfer items, 1 eating item, 1 toileting item, 1 oral hygiene item, and then 2 walking items. And if you're tag teaming with OT, then PTs might do certain GG items and the OTs might do other GG items. So it depends on the facility that you work in and how those are divided up, or what disciplines are going to be seeing this patient. So PDPM versus RUG levels. So previous RUG levels tracked the functional independence rather than the functional dependence. There were higher points assigned to higher levels of independence. This approach is consistent with functional measures in other care settings. So the PDPM is more consistent with the way things are done in an inpatient rehab facility with the PPS. So under the previous RUG model, if the codes are if you're checking off the code that the activity did not occur or only occurred once, these items are assigned the same point value as if they were independent. But more than likely, if there was a reason why the activity did not occur, it was more likely because they were dependent or couldn't do it for whatever reason. It was observed that patients who were unable to complete an activity had similar PT and OT costs as dependent patients. So kind of like what I just said, under that last note of the previous RUG models and how they were assessed, if you weren't able to see a patient do something, that doesn't necessarily mean that they were independent, because if you were able to have them do it, then you would have been able to accurately assess it. But if for some reason they weren't able to, then more than likely they're dependent for at least some portion of that assessment. So they are grouped into the dependent phase for the purpose of point assignment, and we'll see what that looks like next. So here's the function score construction based on the OT and PT. So the top half of this picture here shows the non-walking items, and then the bottom half shows the walking items. So you're scoring them 4 through 0 based on whether they're independent, need supervision, partial moderate assistance, substantial maximal assistance, or they're dependent, refused, not applicable, not attempted due to environmental limitations, safety concerns, something along those lines. So it puts those classifications based on the score that's written on that right-hand side. On this next screen, you can see the specific section GG items that we discussed. So we mentioned there were 3 self-care items. So one of them is eating, one is oral hygiene, and one is toileting. And then for mobility, we've got quite a few here. So a sit to lying assessment, lying to sitting on the side of bed, sit to stands, chair and bed to chair transfer, toilet transfer, walking 50 feet with 2 different turns, and then walking 150 feet. So it classifies whether they score a 0 to a 4 on all of those, and then the mobility ones tend to average based on which GG item you're looking at. So let's kind of back up just a moment, looking at inpatient rehab versus skilled nursing facility. So in the inpatient rehab, Medicare pays for 90 days of coverage per stretch, with the first 60 days covered fully. Again, this requires no pre-qualification and no pre-qualifying hospital stay for Medicare coverage. The average length of stay in most inpatient rehab facilities is 12.4 days, and the Medicare payment is via PPS. In the skilled nursing side, Medicare pays for the first 100 days per stretch, with the first 20 days fully paid for under certain conditions. You must have a 3-day pre-qualifying stay for Medicare coverage. The average length of stay here is 26.4 days, and the Medicare payment is via PDPM. All right, now we're going to move over to long-term care. So once a skilled benefit is exhausted, so again, over that 100 days mark, or when the residents no longer required actual skilled intervention, they transition to a long-term care facility, or even just maybe in that same facility, but as now a long-term care resident as opposed to a skilled nursing resident. Leading causes of long-term care admission would be all causes like decreased cognition, incontinence, increased falls, or maybe even decreased functional status. In 2006, long-term care utilization was 3.5% of the population aged 65 or older. In 1982, it was 7.5% of the population. So there's speculation as to why that number has decreased more than half in 30 years. Is it because it's too costly and we have better access to healthcare, so we're able to keep people healthier longer in their own home and their own environment? Maybe they have a better support system at home with loved ones or caregivers coming in to help them. Or are we just looking at it now because the population hasn't gotten to the age where they're too old? We've been telling you that, you know, these baby boomers are getting older and older every year. So the fact that we've got such a high number in the baby boomer population right now, we might see a swing back as the population continues to age. Long-term care facilities include the assisted living facilities, adult daycare, home care, or sitter services. And these are non-skilled care under Medicare Part A. No regular skilled intervention is provided here at these facilities. Services provided could be administration of medication, maybe they provide ongoing restorative, recreation care, or even social activities. If rehab care is needed in this facility, it's billed out under Medicare Part B. So the same rules apply as any Medicare Part B patient would have, and so that is how that would be billed out, because it's not billed out under Medicare Part A. Long-term care, because the care is considered non-skilled, Medicare does not cover this cost, so they're not paid for their living arrangements and their expenses there. It's paid out of pocket, maybe by private insurance if you have that type of insurance that covers that, or by Medicaid if the residents qualify based on their income. Medicaid is the primary payer for most long-term care facilities. So if you think about this, again, it says Medicare does not cover the cost. It doesn't cover the cost of just, again, the living arrangements for a long-term care facility. If they need some sort of skilled intervention while they're in a long-term care facility, it might just be short-term, where they're seeing for PT under that Medicare Part B service for, you know, maybe 2 weeks to 4 weeks, depending on what the specific diagnosis is. But it's not a long-term thing, and that's not the reason why they're in long-term care facilities. 29% of all long-term care residents are eventually discharged to community because they have stabilized or recovered. And the average length of stay in a long-term care facility is 341 days. That's a pretty significant time. And so that's where making sure these patients stay as strong and healthy as possible is really important to hopefully get them back to their community, whether that be back to their specific home, or maybe it's with family and loved ones, or some other type facility. So because of the long-term and the average length of stay for most of these patients and residents in a long-term care facility, there's a large variety of patient population. You might see patients that are independent ambulators, or maybe some that are completely bedbound. But keep in mind, we don't want to underestimate the ability of the patient just because they're in the long-term care facility. So making sure that we know what we're assessing and why, and not just making assumptions because the patient is in an LTC. Frailty is one of the big problems that we see in long-term care facilities. Frailty is defined as the biological syndrome of decreased reserve and resistance to stressors resulting from cumulative declines across multiple physiological systems and causing vulnerability to adverse outcomes. So there's 5 characteristics of frailty, but if you have 3 or more, then patients are considered frail. So these 5 characteristics are unintentional weight loss of more than 10 pounds or more per year, general feeling of exhaustion, and that's going to be more of a subjective thing from the patient's self-report, weakness, slow walking speed, and low levels of physical activity. So here's kind of just a description that's in your book that talks about causes of frailty, and you can just see how these can lead from one problem to another depending on how they're doing and how they're reacting to their environments, whether they're staying active, whether they've got pain that's limiting their activity, whether they start to have decreased balance and have a fear of falling, or possible fractures due to falls. So we've got to look at this to determine the frailty of our patients whenever we assess them in most facilities, but specifically long-term care facilities. So here's a test for frailty. It's called the Modified Physical Performance Test, and I'm sure this is one that you all are familiar with. But here's just the basics of this test to see how functional the patient is and whether they would be considered frail or not. Screening in a long-term care facility, periodic screens are really necessary to determine if the patient is progressing or regressing in their functional ability. If you note a change in the status, PT may determine skilled intervention is necessary or required, or possibly they need to be moved into more of a restorative program. Determination that skilled intervention is required should be an objective process whereby the PT understands the payer definitions of skilled therapy and what's appropriate for that patient given the facility that you're in. So systems review, it's not that different than what we would do in any other setting, but keeping in mind with these long-term care facilities, do we have, a lot of these patients are going to be older, so do we have a vision or a hearing loss? Need to differentiate poor cognition from poor healing, poor cognition from poor hearing, it should be poor hearing, and lack of interest from poor vision. So making sure that we're not making assumptions about this patient just because they're not doing what they ask us or what we're asking them to do. Maybe they just didn't hear us. So we need to make sure that we're differentiating between those. So please make sure and fix that poor cognition from poor hearing, not healing. And then what about bowel and bladder function? We see a lot of incontinence issues in patients as they get older. And incontinence is highly associated with impairment in ADLs, also present in dementia and with some medications too. And then looking at the cardiovascular system, what kind of endurance or aerobic capacity tests do we do on these patients, and what is appropriate depending on the patient in front of us. Strength. Like we've talked about before, muscle strength is a predictor of function in the older adult. We tend to make assumptions again that most long-term care residents have severe strength deficits, but maybe they do, maybe they don't. Again, if they're an independent ambulator in the facility, they're probably not as weak as our patient down the hall that's bedbound. So we need to make sure that we're assessing them appropriately and using objective data to determine their level of independence or dependence. So, for example, much leg strength is required to stand up from a chair, and so you can assume there's a decrease in reserve strength if the patient's unable to stand up on their own. Manual muscle test does not necessarily correlate with functional tasks, especially for a lot of these older long-term care residents, and functional testing might be the best thing for them. So functional assessment might be difficult to get these patients or residents to follow directions due to vision or hearing issues, maybe even dementia or depression issues. And you might find appropriate testing for your patient based on outcome testing that you guys have done before and are familiar with. The table 26.2 on page 493 in your text provides a number of different functional assessment tests that you can do on these patients. Because again, maybe manual muscle test isn't quite the appropriate thing to do for your patient. You need to come up with a functional assessment to assess where they are today and assessing it into the future as well. Exercise. Self-efficacy is the confidence in one's ability to carry out a specified behavior. So it's really important that we help our patients see the benefits of exercise and want to improve or want to get better. Help them find something that they can do safely, because it allows them to do something with confidence. If they don't feel confident doing something, they're more likely not to continue to follow up. Self-efficacy has been shown to be a predictor of stair climbing ability, balance, and general functional decline. Older adults can adapt physiologically to exercise training just like younger adults do, but specificity needs to be incorporated in this. A lot of times we just assume that our long-term care residents are too frail or unable to do any sort of strength training, but we can't assume that's always the case. Maybe we're being too conservative. Maybe we can be a little bit more motivational for them. We've definitely seen improvements with both strength training and endurance training for our patients in the long-term care facility. Gait training and ambulation. So keep in mind, gait training is considered a skilled intervention by Medicare when a therapist needs to give specific instructions verbally or manually to improve the gait pattern. A gait assessment needs to be made to determine the impairments causing any abnormalities, or recommendations need to be made for assistive devices. So for our patients maybe in the long-term care facility, maybe we get orders to do a gait assessment, and Medicare will pay for that, especially if we need to help them be safe in their environment. Or maybe we need to make a recommendation for an assistive device. So Medicare will pay for that, and then we just have to determine, how long that therapy needs to go on, how long that skilled intervention is actually necessary for. Once we determine that skilled intervention is, or that whatever we're providing is not skilled anymore, we can switch it over to maybe a restorative nursing program. So if there's no more improvement that can be made in the gait pattern, or once we've made our recommendations and they're doing fine on their own, but maybe they just need a little bit of help, or just someone to go and walk with them, but otherwise it's not a skilled intervention, then we can switch them over to a restorative nursing program. So each facility has their own way of doing this, or maybe they have recreational therapists that help with this kind of thing. So again, but if it's not a skilled intervention, Medicare is not going to be paying for it any longer. If it is something that is skilled, we need to make sure that we're documenting appropriately such that Medicare will pay for it. Continuing our screen and evaluating the patient. Again, we talked about the strength testing, and maybe that is appropriate. Maybe it's not most appropriate for this population. But if a resident cannot walk without using his arms to support the body because of some sort of lower body weakness, it can be presumed that the resident has lost 75% of their reserve strength. And so this is where it might be necessary to use functional tests to determine the patient's strength versus just manual muscle test. And then lastly, efficacy and exercise. Do our residents know why we want them to do certain exercises? I think it's really important to make sure that we've clarified the exercises we want them to do, make sure they feel safe and comfortable doing those exercises, and make sure they understand why you want them to do those exercises. You also want to make sure that the patient believes they can do those exercises safely and on their own, because if they can't, they're more than likely not going to do them. So self-efficacy has been shown to be a predictor of stair climbing ability, balance, and general functional decline in older adults. So if they don't trust that what they can do is going to be safe for them, or that they know how to do it, then they're probably not going to. PT practice has been shown in long-term care facilities to reflect very low expectations by both the therapist and the resident. And it is, again, really important that we assess each individual individually and not just make assumptions based on the fact that they're in a long-term care facility. So just keeping in mind that there's probably always better ways that we can provide skilled services to our patients, and not to make those assumptions about what our patients can or cannot do without using objective data to help our patients the best way we know how.